This episode of Transmission Interrupted was recorded September 4th, 2024.
This is Transmission Interrupted, the podcast series from NETEC, the National Emerging Special Pathogens Training and Education Center. Welcome to Transmission Interrupted from NETEC.
Hi, everyone, and welcome to Transmission Interrupted. My name is Lauren Sauer, and I'm an associate professor at the University of Nebraska Medical Center and the director of the Special Pathogens Research Network with NETEC. For those of you not familiar with NETEC, our mission is to set the gold standard for special pathogens preparedness and response across health systems in the United States, with the goals of driving best practices, closing knowledge gaps, and developing innovative resources. NETEC works alongside and in cooperation with the CDC and is funded by ASPR, the Administration for Strategic Preparedness and Response. On today's episode, we have a very special guest. Dr. Jana Broadhurst is here with us to talk all things testing and surveillance for H5N1. Dr. Broadhurst is an associate professor in the UNMC College of Medicine, Department of Pathology, Microbiology, and Immunology, and she completed her MD and PhD in immunology at the University of California, San Francisco, followed by residency and fellowship training in clinical pathology and medical microbiology at Stanford. She currently serves as the medical director for the Nebraska Biocontainment Unit Clinical Laboratory and Emerging Pathogens Laboratory at UNMC. And one thing that's great about Jana is her focus on applying novel technologies to solve patient and community-centered challenges in infectious diseases. And it's really central to her work in bridging diagnostics and infection prevention control requirements for vulnerable populations in and out of emergencies. So welcome to the show, Jana.
Thank you, Lauren. Very happy to be here.
Let's start with an overview of the current status of H5N1. So the U.S. is experiencing a unique part of a broader global HPAI outbreak. In the past year, we've seen 48 states experience poultry outbreaks. 14 states see outbreaks in dairy cows, which isn't an animal we've historically seen infected with flu A. And on top of this, 9 dairy workers who are working with infected herds have been infected themselves. I think it's safe to say we got lucky that they've only had mild symptoms, primarily conjunctivitis and mild respiratory symptoms, but this may not always be the case, as we know to be true with H5N1. So we know there's limited surveillance. What would you say are the main challenges we face in monitoring this outbreak effectively? Are there regions or populations that are particularly underrepresented in current surveillance efforts?
Well, to talk about H5N1 surveillance, I think we have to remember that this is part of a large and complex system of influenza surveillance that happens globally in both animal and human populations. So let's take a step back and put H5N1 surveillance into that broader context. And we'll start with a reminder that there are many different types of influenza viruses. And influenza A and B are the types that cause human disease, with influenza A being responsible for pandemics and some of our seasonal influenza disease. Wild birds are the natural host for influenza A, and there's a tremendous diversity of influenza A viruses that are circulating in wild birds, many of which are traveling along global migratory routes and shedding the virus into the environment. And among the many influenza A viruses circulating in wild birds, certain subtypes have the ability to infect poultry, domesticated mammals, including pigs and cows, and a wide variety of wild mammals. The viruses can mutate and adapt in all of these hosts, and in cases where more than one influenza A virus is infecting the same host, they can swap pieces of their genomes and generate new viruses. And sometimes that gives rise to more virulent strains that can cause really devastating outbreaks in animal populations. The more these viruses circulate and change in animals that are close to people, the higher our risk for having spillover into human population. So getting back to H5, this is a subtype of influenza A virus that has spread from wild birds to poultry and mammals for many years. And some strains of H5 subtypes have caused high mortality in birds, and we call those highly pathogenic avian influenza viruses, or HPAI. And in the past, there's been spillover of HPAI, H5 viruses into people that cause severe disease. So when we talk about surveillance for H5 viruses, we're talking about surveillance in wild birds, in poultry, in domestic and wild mammals, and now in people. And all of these surveillance systems are connected. In the U.S., animal surveillance for H5 is carried out by multiple agencies, including the USDA, the USGS, and the U.S. Fish and Wildlife Service. And these surveillance systems involve the direct testing of live and dead birds, as well as environmental testing, primarily for virus that's shed in fecal material from birds. So birds, just like people, shed influenza viruses from their GI tract and into their fecal material. On the human side, we also have a variety of approaches to surveillance that build on these broader systems of surveillance for influenza. Now, thinking about H5N1 specifically, we know that the people who are at highest risk are those who are in close proximity to birds or domesticated mammals like dairy cattle that are known to be infected. So one approach is to monitor and test people who have been exposed to animals that are known to be infected. So those individuals can be monitored for symptoms, and they can be tested specifically for the H5N1 virus if they become sick. And this is work that the CDC is doing in collaboration with the USDA, again, so that we're linking our animal and human-based surveillance. Now, we know that we're not going to catch all events of spillover from animals into humans by taking this approach. And we have to be able to also detect the virus in people for whom we didn't know there was a high-risk exposure to infected animals. That approach is one where we can test clinical samples, respiratory samples, that are submitted for testing for influenza. Now, it gets a little more complicated here because we have so many different diagnostic tests for influenza, and we use them differently in different healthcare settings and at different times of year. And they give us different information and clues to whether or not the H5N1 virus is present. And we'll talk more about those diagnostic tests and platforms and which ones may be useful for onboarding H5 specific testing if that's needed moving forward. One more thing I wanted to mention about surveillance for H5N1 that's part of our public health surveillance process is that in addition to detecting the virus in animals and people, it's also important that we surveil for changes in the virus that might impact how the virus behaves or how well our current tools work. There can be mutations that impact the ability of diagnostic tests to detect the virus, and mutations that can also lead to changes in the virus that make antivirals and potential vaccines less effective. So this type of surveillance requires sequencing so that we can detect changes in the genome of the virus that influence these different behaviors and the efficacy of our current tools.
Thanks so much for that comprehensive review. It's just unbelievable how much is going on out there with regards to surveillance. One of the methods that's been gaining attention, I think since its use so much more comprehensively than we'd previously seen, is wastewater monitoring as a surveillance tool. Can you explain what wastewater surveillance is and how it might be used to track H5N1?
Absolutely. So wastewater testing for infectious diseases has been around for quite a while. It's been used, for example, in broad public health surveillance for polioviruses, which are viruses that are shed in fecal material. And respiratory viruses, which may be less known, also generally are shed in the feces, again, from both animals as well as from people. This became more broadly appreciated during COVID when it became clear that detection of SARS-CoV-2 in wastewater can be done effectively and provide an earlier signal of community transmission than our other conventional healthcare-based metrics. So what is wastewater monitoring? Well, wastewater is collected from gray water and from sewage sources in what we call sewer sheds. The effluent is coming out of buildings and aggregates into larger sewer systems that eventually make their way to a wastewater treatment plant. So most of the wastewater testing in the U.S. is testing samples that are collected at municipal wastewater treatment plants. And these sites are now connected into what is called CDC's National Wastewater Surveillance System. And this is a system of more than 1,200 sites that covers all 50 states in the U.S. And around a third of the U.S. population is represented in this surveillance system, which is really impressive. That's almost 130 million people. But it's not everyone. So there are some limitations to the information that we are gathering through wastewater testing. So the data is produced really at the sewer shed level. Now, sewer sheds differ in sizes, but this is pretty granular when it comes to community-based surveillance. So the information can be quite specific to a community, and it can also represent larger trends in a location or region. So testing for H5N1 specifically in wastewater began over the summer. We've known for a couple of years that we can detect influenza viruses in wastewater, but it really wasn't until this summer that the testing capabilities were implemented for specific detection of H5. So now there's more than 150 sites across 41 states that are reporting H5 specific test results to the CDC every week. And we are seeing positive test results in various locations each week.
It's great to know that we have such a strong tool in our toolkit for surveillance. Why is wastewater monitoring such an important tool in our surveillance arsenal, especially for these types of viruses like H5N1?
This type of community-based surveillance is really essential because our primary other method, which is to test samples that are submitted for clinical testing, relies on people having healthcare access and utilizing healthcare services for testing, which of course excludes many of our higher risk communities in the U.S. So H5N1 allows that community-based surveillance without the need for utilizing healthcare services. So that's a really important point. It's also important that these sewer sheds where wastewater is aggregating before getting to a wastewater treatment plant includes both human and animal effluent wastewater. So this is actually a surveillance system that broadly can detect both human and animal sources of viruses like H5N1. And that's been demonstrated. Another aspect of wastewater testing that's important that we really learned over the course of the COVID pandemic is that we, at least for SARS-CoV-2, know that we see increases in detection of virus in wastewater before we see rises in clinical cases. So again, an early warning signal that precedes our healthcare-based metrics. We may find that that also is the case for the monitoring of zoonotic influenza viruses as well. Another important aspect of wastewater testing is that the viral material that we detect from wastewater is intact enough that we can actually sequence the virus from this testing approach. And that's really important. Again, as we talked about, the ability to sequence the virus allows us not just to detect it, but to characterize it for changes that can impact the efficacy of our diagnostics, therapeutics, and vaccines.
So switching gears a bit, I think that summary of this tool of wastewater testing to support community-based understanding of where the virus is or where the virus was or where the virus will be. Beyond wastewater testing, what other testing strategies do we currently have or are we using to detect H5N1, or maybe some that are even in development?
Again, we do have current testing systems in place for both animals and for people. So animal testing can rely on direct swabbing of animals as well as environmental testing. On the human side, we rely on both clinical and public health laboratories. Now, on the clinical side, we have a lot of different tests for influenza. And some of those tests give us information about the type and subtype of influenza virus detected in the sample, and some of them don't. So many of our tests will be generic for influenza A. Now, luckily, most of those tests we know will pick up H5N1. And so right now, and again, this could change as the virus continues to evolve, but right now, our clinical tests appear to be inclusive for H5N1 that's currently circulating. So that's good news. But that leaves us with the conundrum of how to pick out H5N1 virus cases in the broader set of influenza A seasonal influenza virus cases, meaning H1N1 and H3N2. So this is something that really is still being worked out in terms of how those protocols will work best at different healthcare settings. But broadly speaking, confirming the presence of H5N1 in a person who's tested positive for flu does require that that sample be tested at a public health laboratory. And all of our states have the ability now to test specifically for H5N1 and confirm that that is the influenza virus that's present. So these tests are PCR-based tests that are looking for specific nucleic acid targets in the virus that can give us the subtype level information. Many public health laboratories are also able to perform the sequencing necessary to further characterize the virus and look for those mutations of interest and to better understand how the virus is evolving over time.
So when we think about the clinical setting, which I think you were just starting to get into a little bit in our last question, there's a lot of potential to see these patients in the clinical setting. I mean, I think we've been very lucky that we've only had patients that haven't needed hospitalization and have been able to convalesce at home. But there is a chance that we could see a lot more of these patients in our emergency departments, in our inpatient units. And as someone who has made a lot of tests, used a lot of tests, thought about testing quite a lot, in the clinical setting, what are the main concerns you have when it comes to diagnosing H5N1? Are there specific challenges that clinicians are facing?
There certainly are. H5N1 influenza presents many of the same diagnostic challenges as most infectious diseases, and that it can cause infections with or without symptoms, and the symptoms aren't specific to this particular virus. So making the diagnosis starts with the risk assessment and clinical suspicion. And that's something that is really difficult to do consistently, particularly early when cases aren't common, and it's not something that clinicians are used to seeing. One of the particular challenges that we'll have with H5N1 is that cases may occur outside of our regular influenza season. So again, the way that we test for influenza in our healthcare settings in the US, it varies across the year. We test for flu more during flu season, and that makes sense. So now we'll be faced with needing to recognize potential cases of non-seasonal influenza and ordering those appropriate tests outside of influenza season. So that's going to be one of our challenges. We know, as you mentioned, Lauren, that the cases to date have not had a typical influenza-like illness clinical presentation. So unusual presentations like conjunctivitis without broader systemic illness can also present a diagnostic challenge, again, in raising that appropriate clinical suspicion and getting the right tests ordered. We certainly will have a continued challenge in knowing how best to test and interpret our current flu tests. So again, some of these tests are generic for flu. Some will tell you it's flu A. Some might give information on the subtype for seasonal influenza subtypes like H1N1 and H3N2. Clinicians will have to understand what their tests are telling them and when there are clues that should guide them to refer those samples to the public health laboratory for H5 specific testing. Currently, H5 specific testing is only available in our public health laboratories. And that can certainly lead to delays, sometimes up to days, in getting that H5 specific result. And that will leave clinicians and patients in a difficult position of knowing how best to manage patients and to manage transmission risk in the healthcare setting while awaiting that result. So moving forward, as the need evolves, there are certainly opportunities to improve our clinical testing capabilities to get more rapid H5 specific results available.
So how do you see the integration of all these surveillance methods that we talked about, like wastewater monitoring, for example, with these clinical testing strategies that sound exceptionally complicated in and of themselves? Is there a way to make these approaches work a little more seamlessly together?
Well, we started to learn more about how these approaches can be used together more effectively during the COVID-19 pandemic. We know that there are huge challenges in scaling up clinical testing and sustaining large testing programs over an extended period. There's challenges in laboratory capacity and supply chain and in testing fatigue among our communities. And so we need more effective strategies to target those clinical testing resources. And that's a real opportunity as we look at animal-based surveillance, environmental testing, wastewater testing, and how those surveillance approaches can, particularly early before there's widespread transmission in human populations, to hone in on areas of higher risk and utilize proactive testing approaches in communities that are known to be in a higher exposure risk setting. This can happen at the state level, this can happen at the community level, and this can happen at an even more granular level with communities, again, that are experiencing a higher known exposure risk. So we haven't yet accomplished that kind of coordination between these different testing tools. But we know it's possible, and there were some successful pilot programs during COVID that gave us some operational insight, as long as there's very close coordination, of course, between all of the groups involved in these different testing approaches. And coordination is never simple, but a large part of that coordination is in getting all of this data into one place so that the data can be interpreted holistically by the right public health stakeholders who can mobilize these resources. And so that comes down to IT infrastructure and data analytics and dashboarding. And that's something that developed quite a lot during the COVID-19 pandemic and really builds on the backbone of excellent tools that have been under development for decades for influenza surveillance.
Well, it sounds like you will not be out of a job anytime soon. There's a lot more work to do. So looking ahead, what do you think are the next steps for improving H5N1 surveillance and diagnostics, or even, high-path flu more generally? And are there any innovations on the horizon that you're particularly excited about?
I think what we need to do, for sure, is take our lessons learned during previous influenza outbreaks and pandemics, and more recently during the COVID-19 pandemic. And we've learned the importance of early detection of infections. And we know that in people, we can detect infection often before there's symptoms or even when symptoms are not going to develop. And that early detection is so critical for reducing transmission. But that means that we need to be able to test people where they experience their risk for infection, at home, at work, and at schools, and not rely on people developing symptoms and accessing healthcare resources for testing. If we wait until people are sick and show up at our hospitals, then we've really missed the opportunity to prevent transmission, again, where people are actually experiencing their risk. So how do we do that? Well, we know that the only way to make testing accessible and distributable is to have testing methods that are non-invasive and that can be performed on specimens that are self-collected. We can't rely on having to get healthcare workers out there into all of these settings to collect samples. And this is an area where other sample types, like saliva, have been really helpful. So just like SARS-CoV-2, we can detect influenza viruses in saliva. And this can be one approach by which we can get testing more broadly out there into community settings, again, for early detection, even before symptoms develop.
It sounds like there's so much more work to do. We're lucky to have people like you really working hard on this problem, both at the very local, clinical environment, but also at this much broader global problem-solving environment as well. So look forward to hearing about some of these advances as they move forward. And Dr. Broadhurst, thank you so much for sharing your insight on this critical issue. It's clear that there's a lot of work to be done, but also a lot of potential in the tools and strategies that people like you are developing. Thank you again for joining us today. Any last words you want to impart on us, last bits of wisdom?
Lauren, thank you so much. This has been a This has been a great conversation, and I appreciate you moving forward the public information that's available.
I'm sure this will be a very popular podcast, especially as we enter into flu season. So thank you again so much for joining us today. We hope you all enjoyed this episode on H5N1 testing and surveillance, and we do hope you'll join us for future episodes on a wide range of topics from healthcare worker safety to personal protective equipment, and even more about infectious diseases of all kinds. Dr. Broadhurst, thank you again so much for joining us. And for all of our listeners, if you have any questions for NETEC or ideas for future shows, please feel free to contact us at info@netec.org. That's info@netec.org. Or find us on the web at netec.org/podcast, where you can subscribe to future episodes and find more information on today's topic. We'll see you next time on Transmission Interrupted.
You've been listening to Transmission Interrupted, the podcast series from NETEC, the National Emerging Special Pathogens Training and Education Center. Learn more at netec.org.